for this session on thalassemia. Every year we celebrate International Thalassemia Day on 8th of May, and this year the theme is Together with Thalassemia, Uniting Communities and Prioritizing Patients, with powerful slogans like We Are One and Patients First. So we as IIP West Delhi celebrated International Thalassemia Day and are still celebrating. We celebrated it on 9th of May at Deen Dayal Hospital. It was very well organized at a very short notice by HOD sir, Dr. Arun Agarwal sir, and Dr. Ripudaman ma'am and Dr. Samarjeet Grover. So we had a painting competition for children. Almost 30 to 35 patients were admitted that day in the thalassemia ward for the therapy. So we had a drawing competition for them and a parental awareness session by the nodal officer, Dr. Rohit. And then we felicitated the young budding children, and that is how we celebrated. And let us begin today's session, also the panel discussion. And now I'll invite our President Smita Mishra ma'am, dynamic president under whose leadership we are doing everything this year. And Dr. Smita Mishra ma'am is the President IIP West Delhi and head of the department Pediatric Cardiology, Manipal Hospital. And Dr. Smita Mishra ma'am.
Uh, Dear Radhika, thank you so much for introducing me, and Dr. Alok Bhandari sir for making the opening remarks. This actually and saying good words to us, and I can say that we are only trying to follow the path, and we are only trying to rise to the occasion because we had a very robust legacy for the IEP. Delhi West. So, Rohit, I want to share my slides now. Just a minute. Can you see my slides?
Recording in progress.
Can you see my slides?
Yes, ma'am.
Yes, ma'am. Yes.
So this is the first slide, which is Dr. Radhika told about. We were very lucky that we could have a cooperation and collaboration with DDU because of Dr. Arun Agrawal and Dr. Ripdaman ma'am, who is our EB also. So you can see the children. It was really good surprising element into that because not regularly as a pediatric cardiologist I look at the thalassemia patient, but here you can see the patients are properly given the blood transfusion, properly given the iron chelation, and that is taking away that the typical faces. You don't see that because though children are of adolescent age group. So this is the photograph of that day. Coming to the introduction of our team, Dr. Radhika, my secretary of IEP West Delhi, Dr. Richa is president-elect, Dr. Samarjeet Grover, our finance secretary, very active and efficient. Dr. Puneet Kumar, everybody knows about him, is editor, Pediatric Connect. Dr. Dinesh Goyal and the Dr. Maninder Dhaliwal are our ex-officio president secretary. We also welcome Dr. Mukesh Dhanka because he is not here. He should have been here for the moderating the session, but he had really a serious issue in the hospital and emergency. And Dr. Manish Gupta is central IAP member. I don't think he has joined. Dr. Mukesh Verma is our most active person and the guide also. So we are very lucky to have Dr. Alok Bhandari, Dr. Mukesh Verma, Mukesh Dhankar with our team. This is our executive board, Dr. Prashant Seth, Dr. Rashmi Grover, Dr. Shravan Gupta, Dr. Rashmi Gandhi, Dr. Gagan Malhotra, Dr. Ribdaman Kaur. We also have our advisors, Dr. Bhandari is there, Dr. Deepak Gautam, Dr. Piyush Khanna, Dr. Sandeep Taneja, Dr. Manish Chopra, Dr. Uttam Pal, Dr. Lalit Mehndi Ratha, Dr. Vikas, and Dr. Vineet Sehgal. And co-op member Dr. Pankaj, Dr. Ram Asre, Dr. Shweta Gupta, Dr. Vishal Vaidya, and also Dr. Sunil Bhasin and Dr. Ritu Chawla. So I welcome all of you and thanks for working for us. And now I want to introduce chairperson of today, Dr. Shravan Gupta, Dr. Alok Bhandari, and Dr. Pankaj Goyal. I will request. So Dr. Mukesh Dhankar is not there, and Dr. Alok Bhandari, can I request you to introduce our panelists for today?
Yes, we have an excellent elite panel with Mukesh Dhankar was supposed to be coordinating this as moderator. Dr. Manas Kalra is a well-known name in hematology as a senior consultant at Sir Gangaram Hospital, and he's also honorary secretary of PHO chapter of IAP for last 2 years. He is a gold medalist in MBBS, MD, DNB, and he is a real gold for us. Wherever IAP Delhi is struck with anywhere, he's always there. He did his FNB pediatric hemato-onco in 2008 to 10, and then 2 years fellowship in leukemia neuro-oncology from Sydney, 1 year fellowship from again Westmead, Sydney, then winner of Young Investigator Award. He is still quite young, author of over 60 papers in pediatric hemato-onco, thesis guide for DNB pediatrics, mentored more than 30 FNB and IAP PHO students, EB member of Indian Society of Neuro-Oncology. Previously, he was assistant professor at KMC Manipal, consultant at Apollo Delhi, has been an EB member of IAP Nord Delhi, webmaster of IAP PHO chapter, and has delivered more than 350 lectures in various conferences and CMEs. So welcome, Manas. I think Varsha को introduce Dr. Sharvan कर दें या
Dr. Shravan कर दीजिए please.
Dr. Sharvan, are you there? Yeah, Dr. Pankaj Goyal. Please introduce Dr. Varsha Mishra.
Please unmute yourself. Dr. Shravan, unmute yourself.
नहीं तो
Dr. Shravan,
Dr. Pankaj Goyal.
Sir, please continue, Dr.
चलो
Bhandari.
Varsha, welcome to IAP West Delhi platform. She is an assistant professor in Department of Pediatrics at National Cancer Institute, AIMS, New Delhi. She had MD Pediatrics as again a gold medalist, fellowship in pediatric hemato-onco, fellowship in bone marrow transplant, and has special interest in thalassemia, quality of life, leukemias, lymphoma, emergency cancer care, and cancer survivorship. So perfect faculty for today's session. And Sandeep Jain is again pediatric hemato-onco at Rajiv Gandhi Cancer Institute, Rohini.
So now I give over to Dr.
Please.
Rajita to continue.
Thank you, ma'am. We'll start this program by, we should always start with the Saraswati Vandana. So this is a very special Saraswati Vandana because this has been sung by Dr. Ripudaman Kaur. Rohit,
या कुण्डेन्दु तुषारहार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डिता या श्वेत पद्मासना या ब्रह्मा चतुशंकर प्रभृतिभिः देवैः सदा वन्दिता सा मा पातु सरस्वती भगवती निःशेष जाड्यापहा। या कुण्डेन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्मा चतुशंकर प्रभृतिभिः देवैः सदा वन्दिता सा मा पातु सरस्वती भगवती निःशेष जाड्यापहा।
Now,
Dr.
thank you, Dr. Ripudaman ma'am, and thank you, Rohit. And now we move on to the IAP anthem, the lyrics of which were written by Dr. Smita Mishra, and this was conceived during Dr. Gaba's time and Dr. Richa Parashar.
IAP का यही आह्वान, हर बच्चे की अपनी उड़ान। IAP का यही आह्वान, हर बच्चे की अपनी उड़ान। हम रहे सेवा को तत्पर, रहे सदा आगे बढ़कर। हम रहे सेवा को तत्पर, रहे सदा आगे बढ़कर। संक्रमण कुपोषण आदि इनका करे निदान। IAP का है यही मकसद, स्वस्थ शिशु बने देश की शान। IAP का यही आह्वान, हर बच्चे की अपनी उड़ान। IAP का यही आह्वान, हर बच्चे की अपनी उड़ान। जननी शिशु रहे सुरक्षित, माँ कराए स्तनपान। जीवन रक्षक घोल पिलाए, बचाए उनकी जान। टीकाकरण हो घर घर में, बीमारियों से करे सावधान। IAP का यही आह्वान, हर बच्चे की अपनी उड़ान। IAP का यही आह्वान, हर बच्चे की अपनी उड़ान। IAP का हर एक जन एक है होकर परिवार। थामे रहे हाथ अगर आए किसी पर कोई आँच, होने न देंगे कोई हिंसा। वादा है ये खुद से। IAP का यही आह्वान, हर बच्चे की अपनी उड़ान। IAP का यही आह्वान, हर बच्चे की अपनी उड़ान। हर बच्चे की अपनी उड़ान, हर
Thank you, Rohit, again. Now we move on to a very special song which has been composed by Dr. Smita Mishra ma'am. It is on thalassemia.
If both parents have the trait, thalassemia major may be fate. It's an inheritable disorder. Genetic tests are the help in finding disorder. Pinto is adorable and lovely baby. He was born happy and healthy after he crossed the infancy. He looks like he's sick and a pale baby. Tell me, doc, if he needs some therapy. Doc examined and said, it's serious anemia, I am afraid. Pinto is also spleen enlarged. Hemoglobinopathies are one of the cause. Blood test showed doc was right to suspect Pinto had deficient beta globin chain. If both parents have the thalassemia trait, thalassemia major may be fate. Doc said it is wise to get prenatal screening tests, and they must follow doctor's guidance. Abnormal hemoglobin leads to red cell breakdown. Thalassemia major in baby is best to avoid. Thalassemia major needs care for life, hence prevention is always better and wise. Pinto would need frequent blood transfusion, care for iron load and regular iron chelation. He may have chance get well by gene therapy or bone marrow transplantation. He needs proper nutrition, exercise, and vaccination. For Pinto you need love, faith, and care to keep Pinto in best of health. Let him go to school and mingle with peer. Pinto have to keep morale high and have a cheerful life. Thalassemia is better prevented, so parents must have prenatally tested. Bless you, Pinto, you are adorable, lovely, and brave. Stay safe, stay safe.
Thank you so much. And now I will request Dr. Bhandari sir to give the opening remarks for the today's discussion, and then I will take the questions. Doctor, this is
Ma'am,
because
Dr.
Dr.
Mukesh Dhankar has joined.
Dr. Mukesh
He's back.
Dhankar has joined. That is what I was saying. Our star batsman of the day.
Sir, good afternoon, sir.
Mukesh ji is
Apologies for joining late. There was some emergency in the college because of which I could not join 5 minutes earlier.
Good.
My sincere apologies. My sincere apologies.
Emergencies is handled and you are cheerful. That is good for us.
नहीं सर कुछ काफी बड़ा इशू है. I'll discuss in person. काफी बड़ा इशू है,
चलो
but it's fine.
मुकेश
हाँ जी सर.
मुकेश को अभी इंट्रोडक्शन रह रहा था, वो शुरू कर दें हम बाकी लोग. आई थिंक ही इज अ वेल नोन फेस एंड फिगर in IAP West Delhi, and maybe now with his tenure as executive board member, he is now a national figure. But for others, I can tell you, his initial days education was from Rohtak, Haryana, and then he had multiple working stints, even in West Delhi, Deen Dayal Upadhyay Hospital. He has worked with us. He's an ace swimmer. He was always an active participant of the swimming meets of the doctors, and won by miles. He had completed the swimming length, and the second person was thinking he is the winner because no other person was in sight. That I can vividly remember. And then he went on to do DM in hemato-onco from prestigious PGI Chandigarh. And now he's back in Delhi at prestigious Kalavati Saran Children Hospital as a professor in the department. I think इतना ज्यादा हम ही बोलेंगे तो फिर हेमाटो और थैलेसीमिया पीछे रह जाएगा. आई हैंड ओवर द स्टेज टू मुकेश धनखड़ फॉर दिस.
Right.
अगर ओपनिंग रिमार्क्स के लिए बोला स्मिता जी ने, तो मेरी हमेशा एक ओपनिंग रिमार्क यही होता है कि लेट्स इंश्योर दैट आईएपी ग्रोज, आईएपी वेस्ट दिल्ली ग्रोज. उसके लिए एवरीबडी शुड बी मेड अ मेंबर. ऑल एलिजिबल pediatricians in your areas, in your contacts, should become a member of IAP, and all those students who had become member as a student or associate life member and have now completed, got their qualification, should send a copy of the qualification to Central IAP, and they'll be converted into life members. That is my humble appeal. So,
Right, sir.
over to Radhika or Mukesh. कैसे आप राधिका देखिए?
Sir, Dr. Mukesh Dhankar, please.
Sir.
I'm
Thank
very
you.
happy that he's back.
Thank you.
Dr. Mukesh Dhankar, please continue. We are really very happy.
Right. Thank you for this opportunity. At the outset, I'd like to thank everyone. I would especially like to thank Dr. Smita, the President West IIP Delhi, Dr. Radhika, very hardworking Secretary IIP West Delhi, Dr. Samarjit Grover, and also like to thank my mentor, Dr. Alok Bandari sir, for a wonderful introduction. So starting with the panel discussion, we have three specialists with us. We have Dr. Manas Kalra. He's a senior pediatric hemato-oncologist at Sir Gangaram Hospital. He's also the Secretary of Pediatric Hematology Oncology Chapter of Indian Academy of Pediatrics. He's a close
सॉरी
friend.
मुकेश, हमने तीनों स्पीकर्स को इंट्रोड्यूस कर दिया था.
अच्छा कर दिया था, sorry, my fault.
नहीं,
So
नहीं,
let's
हमने आपका काम आसान कर दिया.
right. So let's go ahead with our panel discussion then. So as we know, thalassemia is a major public health concern, particularly in India. Globally, there are millions who are carriers of thalassemia gene, and in India alone, we have approximately 10,000 to 15,000 new thalassemic children. And despite it being preventable, lack of awareness, and with early screening and access to care, we can probably help the millions who are affected. So as we have already been introduced with our three panelists, so we have privileged to have all these three. I would like to welcome all these three panelists to this webinar today. Thank you for joining us. And now let's try to understand the basics first. My first question is to Dr. Varsha. What is thalassemia and how does it differ from iron deficiency anemia?
I extend a very good afternoon to all the esteemed members present here, and thankful for having me here on this panel discussion. And so, as the question put up is, what is thalassemia? So, thalassemia is inherited hemoglobinopathy in which there is a mutation in the globin chain that leads to change in rate of the globin chain production. It can range from reduced production to complete absence of the globin chain. And the name that thalassemia derives comes from the chain which is affected, the production of the chain which is affected. So, when there is reduced production or absence of a particular globin chain affected, this leads to an imbalance between the association of the globin chains, and this leads to excess accumulation of the extra chains which is available. They make up the inclusion bodies, leading to early destruction of the RBCs and giving an ineffective erythropoiesis picture and a picture of hemolytic anemia. So the normal RBC lifespan is 120 days. It gets reduced to less than 120 days, and there is fall in hemoglobin, and thus the child requires repeated blood transfusion to maintain a certain level of hemoglobin for his day-to-day life function. And as the second question is how it is different from iron deficiency anemia. So iron deficiency anemia is a very common form of anemia that we see because the body does not have enough iron to produce hemoglobin. This leads to low hemoglobin and common symptoms like fatigue and weakness. And this iron deficiency can be because of either low intake of iron, which are the nutritional causes, or it is a defective absorption of iron which is taken inside the body, or a defective utilization of this iron in the formation of hemoglobin. It can be either. So this is the two basic differences in two different types
Right.
of anemia.
So now, as Dr. Barsha has mentioned, these things are two different things. They are not similar. So we need to really differentiate when we're dealing with a patient with thalassemia or an iron deficiency anemia. So Dr. Manas, we would like to know how prevalent is thalassemia in India, and are certain communities more affected than others?
So, thanks again to the organizers for giving me this opportunity. Thalassemia is quite prevalent. So, I would say 4 to 5% are carriers for thalassemia, especially in our region. There are communities where thalassemia is much more common, and despite all the attempts, they say that almost 10,000 thalassemia major children are born every year in India, which is a very big number. You can only imagine how much we have to invest in each and every thalassemic care, regular blood transfusion, chelation, bone marrow transplant. So prevention is better than cure. And these huge numbers kind of tell us that, we should really invest in prevention because in India and all the Mediterranean belt, like Iran, Cyprus, all these areas, Pakistan, Afghanistan, thalassemia is very prevalent, and these areas should have a very aggressive screening, and we should pledge to not have thalassemia children born, and that can only come with the partnership of gynae community, obstetric community, pediatricians, and hematologists. If you look at particular communities, there are Punjabis, Sindhis, um, um, Gujaratis. There are certain in Karnataka belt, Lohans, Gaudas. These have higher incidences of higher prevalence of thalassemia. So, if you screen these communities, the percentage may be a little higher also. But yes, there are certain communities which have thalassemia as much more common.
Right. Thank you, Dr. Manas. So, as Dr. Manas has mentioned, that these are more prevalent in other sub communities with us. So, screening is by which we can prevent the happening of thalassemia. So, Dr. Sandeep,
And just
we would
Mukesh, just one more thing that this is about, when you ask thalassemia, I refer to beta thalassemia. Okay,
exactly
if you
right.
look at E thalassemia, so if you go to the Northeast community, Bengalis, Assamese, and all there, E thalassemia is much more common. So, region wise also there is difference. So, alpha thalassemia is also, in certain tribal communities, alpha thalassemia is more
Is more
common.
common.
So, if
Right.
you go to West Bengal side, E thalassemia will be much more common. Similar way, sickle hemoglobinopathy, sickle belt is different, but I'm not touching on that because mainly I think we are focusing on beta thalassemia today.
Absolutely, absolutely right. So, Dr. Sandeep, we would like to know, why is early diagnosis and public awareness crucial in thalassemia management? And what are the standard treatment approach for thalassemia major? And we are talking of beta thalassemia major in primarily.
So thank you, Mukesh, and thank you, West Delhi IAP, for giving me this opportunity to interact with all of you. So, if we talk about the standard approach of management of thalassemia major, as Varsha has also highlighted, that thalassemia major results because of the defective production of the beta chain of hemoglobin, and there is imbalance between alpha and beta chain. So these patients present at the age of 4 to 6 months with severe anemia and hepatosplenomegaly, and most of these patients will require, almost all the patients will require regular blood transfusion to maintain a hemoglobin, which is crucial for their growth and development. So generally, what we say that we have to maintain a pre-transfusion hemoglobin of around 10 gram percent for these kids. And once they receive like 10 to 15 transfusion, then we have to monitor their serum ferritin. And we know that they are at risk of iron overload because of repeated transfusion, and the chelation should be started. So if we talk about the standard treatment approach for thalassemia major, it is regular blood transfusion and also chelation therapy. But at the same time, we should not forget that we have to monitor their milestones, their growth, their development, vaccination. All this is also crucial part of management of thalassemia major patient, and it should not be ignored. And we should not just focus on the transfusion and chelation. Other parameters are equally important. And at the same time, I would also like to highlight, if we talk about the management of thalassemia major, the only definitive cure for thalassemia major is allogenic bone marrow transplant. We may talk about it later on, but the definitive treatment is that only. Otherwise, lifelong blood transfusion and chelation is the mainstay of treatment.
Right. Thank you, Dr. Sandeep. Now, once we have talked about the prevalence and how it differs from iron deficiency, I would like to know from Dr. Varsha, what are the early signs which should raise our suspicion for thalassemia in children, and how can we, as a primary doctor, identify whether we have a child who is suffering from thalassemia?
Sir, the early signs, so the presentation, the timing of presentation, and the type of presentation, it depends upon the genotype. It depends upon the mutation that is present. So, as Sandeep sir rightly mentioned, that these children, transfusion dependent beta thalassemia children, they present in the latter part of infancy, that is after 6 months of age, which is the time when there is 100% switch from fetal hemoglobin to adult hemoglobin. So these children, they present with severe pallor, signs of congestive heart failure. The parents may just bring the child with a complaint of severe pallor, signs of CHF like irritability, poor feeding. There's like lethargy, and almost all patients of thalassemia, they will have hepatosplenomegaly. And whereas if a child is presenting in the later stages, an older child will present with parents may just come up with progressive pallor, lethargy, poor development, and a child will have a typical hemolytic facies, which are called thalassemic facies, like prominent maxillary bone, depressed nasal bridge, protruded and malocluded frontal teeth. So these are the signs in which a suspicion of thalassemia should be raised, and the child should be tested for thalassemia. Whereas if we come on to thalassemia trait, so they have a very similar picture like iron deficiency anemia laboratory wise. And if a child is not responding to iron supplementation and is being treated as iron deficiency anemia, then the child definitely should get tested for thalassemia trait.
Right. So, as Dr. Varsha mentioned, we should suspect when around 4 to 6 months of age, we have a child with pallor with hepatosplenomegaly, and probably if they have a family history, we should definitely suspect. Otherwise, also we should suspect. So, Dr. Manas, I would like,
I
sir,
would just like to mention one thing. Whenever a
right,
child with thalassemia major is diagnosed, it is very important to screen the siblings, which is very important, and let the family know about the genetic counseling. That should be the part of the thing, which is very important because as Manas also mentioned, that prevention is better than cure, and we always emphasize on prevention of birth of a thalassemic major child.
absolutely. So, Dr. Manas, we would like to know how do we diagnose this thalassemia?
So, first of all, suspect clinically. Varsha has nicely told us when to suspect clinically a child with thalassemia. So, we have to understand thalassemia is a spectrum. One is thalassemia minor, another one is thalassemia intermedia or non-transfusion dependent thalassemia, and third one is thalassemia major. Now, how do you diagnose thalassemia minor? You will have mild microcytic anemia, MCV will be low, RDW will be normal, RBC count will be high. Okay, so if a patient has hemoglobin of 9, 10, 11, and you have microcytosis and there is no iron deficiency, then you suspect that there is thalassemia minor and you do a HPLC, you will find HbA2 above 3.5, 3.5 or more. So this is thalassemia minor. If you talk of thalassemia major, they will have severe anemia, low RBC count, severe microcytosis, MCV will be low, RDW will be very high, and in these patients, when you do a peripheral smear, you will find evidence of hemolysis. You will find nucleated RBCs, which is pathognomonic of thalassemia major. You may find target cells, other types of broken cells as well. It's a dirty kind of a picture with a lot of anisopoikilocytosis. And then you do a HPLC in this patient, and you will find that the HbF will be high and HbA will be very low, and HbA2 really does not matter in these patients. You will have very high HbF and low HbA. This is how you will diagnose thalassemia major. Now you have to understand that as the age increases, your HbF should go down and your HbA should increase. So with age, you have to see where exactly you are testing a child, and you will come to know about that. So in a newborn, HbF will be above 90%, but by 1 year, HbF is less than 5%. So you have to understand this, and then based on the time point, you evaluate. Now, NTDT or thalassemia intermedia, essentially the HPLC or the CBC smear picture is same as thalassemia major. They are mainly distinguished by when the anemia, when a patient presents or how severe is the anemia. So if your anemia is less than 7 before 2 years of age, practically with an organomegaly facial changes, you are like a thal major. If you present after 2 years of age and your hemoglobin is say 7, 7.5, 8, 8.5, then you are NTDT. In such patients, we can try medical management instead of regular blood transfusion also for these patients. Now, often what will happen is that the patient will present to us after receiving a blood transfusion. So a child received a blood transfusion and came to you. Now, in such a situation, HPLC is not the best diagnostic test. If you have high index of suspicion, quickly do the parental study. Parents will be both thalassemia minor, and then you wait for, say, if it is not a leukodepleted blood product, you can wait for say 2-3 weeks and then do a mutation analysis for this patient, and you will identify two different types of mutations or two similar mutations which are responsible to cause thalassemia. And with the help of mutation analysis, you can make a diagnosis of thal major.
So, Dr. Manas, I would like to ask again here one more question, as you mentioned about mutation analysis. So, what are the exact indications where you would definitely like to do the mutation analysis? Otherwise, HPLC is sufficient.
So, Mukesh, I do mutation analysis for all the patients, but really speaking, this is mainly because we want to do the mutation and keep it ready for the family to plan a next pregnancy. Because if they are planning a next pregnancy, we can check the baby whether the baby has those mutations or not. So that
Absolutely.
is one clear indication. Now, sometimes your diagnosis is difficult. You are not able to diagnose. At that point of time, you want to do mutation analysis. If the family doesn't want another child, if and if the diagnosis is very, very certain, classical peripheral smear picture, classical HPLC, really mutation does not change much, but now mutation is easily available. It is not very expensive. We usually do it for all the patients.
Right. So the message is, though for this patient's management, it may not really affect, but for the other sibling, yes, it would help.
Yeah.
So,
And also,
Doctor, sir,
Mukesh, I'll just add one thing. Parents will always tell, नहीं हमें और बच्चा नहीं चाहिए डॉक्टर साहब, इसके
I
बाद हमें
agree.
बच्चा. But sometimes they will come to you when the pregnancy is already quite advanced. In such a situation, if you already have the mutation of the previous baby, then it is very
Very
helpful
helpful.
to
No
quickly
doubt.
do the antenatal test.
Right, right. So, Dr. Sandeep, I would just like to know, what are the major challenges for delivering proper care in government or private hospitals in terms of cost, infrastructure, and access?
Mukesh, as we have learned so far that thalassemia is a disease thalassemia major is a disease where we require regular blood transfusion and chelation, and the requirement of these blood products is quite huge, considering that we have like 10,000 new thalassemic majors which are born every year. So I would first say the availability of transfusion, and which is timely, is the most crucial thing that is lacking. Then it is not just about the blood transfusion, but the quality. That means whether the patient is receiving the whole blood or the packed cell is another major issue. In the periphery, still most of the patients are getting whole blood instead of packed cell. That is another challenge. Then safety of blood transfusion is a major issue, because we know that in certain part of India, the prevalence of hepatitis B, C, and HIV is as high as 10 to 15%. So net testing is not universally followed everywhere, and it is not practically feasible also. So that is also one thing that is like we should emphasize, and somehow we should find ways of doing net tested blood, because these patients require regular transfusion, and unless and until they get safe blood, it is very high likelihood that they will get this infection sometimes or the other. Then the other challenge is, I would say, availability of filters. I know it is not mandatory to have filters, but it is always prudent if somehow the filters are available and they can be made access to all the thalassemia patients, it will be useful. Then, other than the blood, I would say the chelation again. We know that after 15 to 20 transfusion, these patients require regular chelation therapy. The regular availability of chelation drug is a major challenge, and it is not very uncommon to find that most of the patient complain के एक महीने का दवा मिला उसके बाद तो 2 महीने से दवाई नहीं मिल रहा है स्टॉक में है ही नहीं. Then this is another major issue. Then after that, once these children attain the age of 8 to 10 years, then they require special testing for disease management in terms of assessing the iron overload in form of T2 star MRI, endocrine complications, and all these facilities which are required super specialty and multidisciplinary care for the care of a thalassemia child, they are not available in most of the centers across India, whether it is a private setup, whether it's a government setup, all this is this need is huge, and I think we have to go a long way where we can make sure that every thalassemic patient receives the standard of care that they deserve.
Thank you, Dr. Sandeep. So, Dr. Varsha, as we have started talking about transfusion chelation, so I would like to know what are the key difficulties in ensuring safe and regular blood transfusion in a thalassemic patient?
So, sir, when we're talking about safe and regular blood transfusion, when we come to regular blood transfusion, then it is important at the frequency of transfusion is highly individualized for a patient. It depends on his or her level of physical activity, the stage of growth and development, or any existing comorbid conditions if that patient is having. So it is a very individualized plan, and this can be made if we are following a transfusion diary. Like in thalassemia clinics, we maintain a transfusion diary, so which will give us an idea that what is the pre-transfusion hemoglobin that the child is keeping, what is the frequency that is he has been following in the previous year, and it is as per the TIF guidelines. A pre-transfusion hemoglobin of 9.5 to 10.5 gram per deciliter is required, as it ensures good energy levels in the children, good growth and development, and is adequate to suppress intramedullary and extramedullary hematopoiesis. So, keeping all these factors, we can plan for the transfusion frequency for the child in every 2 to 4 weeks, how much he or she requires. Then coming on to safe transfusion. So the principles of safe transfusion is to prevent and to minimize transfusion transmitted infections. And our first line of defense is, deferral of high risk donors, which are prospective high risk donors. And the blood donation should be completely voluntary and should be non remunerated, and screening of donated blood for infections like HIV, hepatitis B, C, and syphilis. And these are the methods to prevent transfusion transmitted infection. And another is to prevent transfusion reactions. So it is very important before the child receives first transfusion, before embarking the patient on transfusion therapy, that there should be complete red blood cell extended antigen testing, which include A, B, O, C, RH, KEL, and the child should receive at least ABO and RH and KEL compatible blood. So it is very important to have that extended red blood cell testing through a through a genotype phenotype panel, and this will help to avoid aluminization in these patients. And another point is to prevent febrile non-hemolytic transfusion reactions, as Sandeep sir was previously mentioning the use of filters. So, the provision of leukodepleted blood should be there. The ideal is to have pre-storage filtration, but then bedside filters will also do the job. And another point to safe transfusion is uh, providing blood in safe volumes and the correct rate of blood transfusion. And the staff should be trained for blood transfusions in these children, and to follow a good hemovigilance structure and adequate reporting of adverse event in these children. So all these measures can lead to a regular and a safe blood transfusion practices in these thalassemia children.
Right. Thank you, Dr. Varsha. So, Dr. Manas, as Dr. Varsha and Dr. Sandeep were mentioning about these safe practices, is it possible for a small hospitals to maintain safe transfusion and prevent complications? Dr.
How
Manas?
does a small hospital sorry, how does a small hospital?
Mala, is it possible to do it in a small hospital? Question is that.
So I think, it is really about from where the small hospital is procuring the blood.
Exactly. Good.
It is about the blood bank.
Mhm.
It is really a small hospital. Say there is a small nursing home which wants to make sure that thalassemia patients come regularly and get blood. But that small nursing home that cannot have a blood bank of its own. So it is the tie-up with the blood bank, and that blood bank has to make sure that it is not giving the blood which has been given by donors who are taking a payback for giving blood. Like Varsha said, they should not be remunerated for the blood donation that they are doing. And how old is the blood? What is the storage facility? Whether the blood is tested adequately or not. I have seen so many children coming from various big medical colleges also, where children have hepatitis B, hepatitis C. So that is really unfortunate if they are getting blood from those places and it is not being tested. So it is very, I would say risky. And I think it is mainly about the good quality blood bank, their quality checkups, and it should be fresh blood and it should be properly tested.
Right.
So if you maintain that link, then obviously your blood will be safe. And as far as complication management is concerned, a person should not be giving 20 ml per kg blood to a child with a 4 hemoglobin. So that basic knowledge also should be there in the person who is managing or transfusing blood. It should not be taken lightly. Blood is a medicine. It's not just, you just order blood and give it to someone. So if it's a child with severe anemia, we always like to give small aliquots of blood. And only once they are stable, you can go up to 15 to 20 ml per kg of blood every time. So I think these are basic things that should be done. Filter is very important. So it should be recommended that everybody should get at least a bedside filter, if not a pre-storage leukodepleted blood. Pre-storage leukodepleted blood is done at the level of blood bank. That is ideal. But if it is not done, then we should give blood through a filter. Now, so many people come to Delhi from outside various hospitals where they are getting blood, from where, say Meerut, Moradabad or wherever, and then they come to us and they say कि वहां पे वो filter नहीं लगाते. हम उन्हें filter लेके भी देते हैं, वो फिर भी filter नहीं लगाते. उन्हें filter use करना नहीं आता, या filter खराब हो जाता है, या blood उसमें जम जाता है. So we always tell them that, the thalassemia patient is the one who teaches the nurse also, because they are so much aware. So we send them to our thalassemia unit. They see the usage of filter and then they go back and educate other parents and the nurses over there. And then the trend starts. So this has happened at many centers where our patients get blood and they just come for a checkup once in 6 months to us. So I think we have to, educate people and spread that message. And CMEs like this, where all the time we talk about that transfusion should not be taken lightly. It's a proper medication. It has to be looked at very carefully.
Right. So rightly mentioned. So Dr. Manas, the message is that we should not hesitate, but at the same time, we should be wise and educated enough to practice safe blood transfusion, give a safe blood transfusion. So Dr. Sandeep, as we have been talking about blood transfusion, and blood transfusion. So what iron overload complications can be there with blood transfusion, and what are the options of chelation therapy?
Uh, So, if we look at our daily requirement of iron, it is just 1 to 2 milligram. And we need to take 10 milligram in our diet, and 10% of it is absorbed, and therefore 1 to 2 milligram is actually met. Now, a thalassemia major patient, say he is receiving 250 ml Paxil, how much iron he is getting? It is like 250 milligram of iron. So his requirement is 1 to 2 milligram, and he is getting 250 milligram iron, that 2 IV in 1 day. And we know that this is going to be every 3 weeks. So we can imagine how much iron he is getting overloaded every 3 to 4 weeks. And where does this iron go? This goes in the liver, heart, and other organs, and therefore causes damage to this organ. So definitely after 15 to 20 transfusion, when the serum ferritin is around 1000 nanogram per ml, we have to start certain drugs which will excrete this iron. So what are the options that we have? So conventionally, in 1980s, we just had one option, desferoxamine, then the Kelfer or Defripron came in picture, and in 2009 or 10, I think, we have availability of this oral drug Defersirox, which is like once a day only. So most of our patients now are on Defersirox since 2 years of age, when they have received 10 to 15 transfusion and serum ferritin is more than 1000 nanogram per ml. And most of the time, we are able to manage their serum ferritin within the acceptable range with a single drug. But whenever a patient comes from far off and he is not adequately transfused and is not chelated properly, we may require to club the two drugs together. And the most commonly we do is Defripron and Defersirox. And in certain emergency situations, so say patient comes with CHF or something else, then definitely this patient require Desferoxazine also. But in routine practice, I would say Defersirox alone is good enough in most of the cases, and in some cases we have to use combination of chelation, which are quite safe, and especially in a BMT setting where we need aggressive chelation to maintain a good liver and heart function before the transplant. There, we add these drugs together for some time, for 4 to 6 months prior to transplant, so as to make transplant a safer option.
Right. So here I would like to add, as Dr. Sandeep has mentioned, that there are only three chelating drugs. And now, if we look at how many anti-epileptic drugs we have n number of anti-epileptic drugs. We never hesitate to use them. Then why do we hesitate to use these three chelating drugs? We can
Correct.
have more CMEs, but we should not hesitate, as Dr. Manas has already mentioned. And Dr. Varsha has mentioned, we should diagnose. We should start transfusing, even if it is a smaller hospital or bigger, it doesn't matter. And there are only three chelating drugs, and it can be learned, and we should start using these three chelating drugs. So now, coming on to some awareness and the policy support policies, Dr. Manas, I would like to know, are there any existing government initiatives or NGO programs supporting the thalassemia care, specifically in terms of bone marrow transplant?
So there is this very famous Thalassemia Bal Seva Yojana. Thalassemia Bal Seva Yojana provides 10 lakh rupees from Coal India. It's a corporate social responsibility project of Coal India, through which they provide 10 lakh rupees to every family whose child is suffering from thalassemia major and is lucky enough to have a matched sibling donor. So if they have a matched sibling donor and we are going to do a transplant for that, because transplant is expensive, whether you do it in a government hospital or private hospital. In government hospital, the taxpayer is paying. In the private hospital, the patient is paying. So through the CSR project, they give 10 lakh rupees to facilitate this transplant. Doing a transplant in 10 lakh rupees for a thalassemia major can be challenging because, the cost is quite a lot. Drugs are expensive. You have to stay in the hospital for 1.5 months. And after that, also, there is post-transplant care. So many tests are done. And there can be complications. So, this serves as a big bridge to do the transplant, and some contribution through the family or through other NGOs or through, you say, PM Relief Fund or other modalities, you can, kind of build that amount of corpus through which a safe transplant can be done. But again, Mukesh, these policies and all are useless if your patient is not in a good condition to get a transplant. So it is very, very important that these children reach the transplant center before, 8-9 years of age. That would be the ideal. They should have good iron chelation. Their liver should be small. Their ferritin should be less than 1000. And, they should be in good condition. And if you do transplant for such patients, your transplant will be less complicated, less money will be spent, outcome will be better. Unfortunately, people don't reach in this stage. They come when they are frustrated of their thalassemia life. They have huge liver, huge spleen, hypersplenism. Their blood hemoglobin is not being maintained. They have all the complications. And if at that point of time you try to do transplant, it will 100% be failed. So government has brought in this nice policy, but again, we need to be very aware and we need to refer these patients on correct time so that transplant.
So right, Dr. Manas, as you have highlighted, correct patient, correct time. So now ये समय है कि मैं एक हमारे साथ एक सज्जन हैं जो एक हमारे थैलेसीमिक बच्चे के पिताजी हैं, जियान के पापा हैं। मुश्ताक जी, नमस्कार।
नमस्कार सर। सबसे पहले बहुत बहुत आई एम ऑडिबल।
हाँ जी, आप ऑडिबल भी और
हाँ
विजिबल भी
जी।
है। सो मैं आपके बारे में थोड़ा सा बता दूं, फिर आप हमसे बात कीजिएगा।
यस
सो मुश्ताक शाह जी हमारे साथ हैं। इनका बच्चा हमारे पास कलावती सरन चिल्ड्रंस हॉस्पिटल में थैलेसीमिया के लिए रेगुलर ट्रांसफ्यूजन पे आता था। जैसे कि डॉक्टर मानस ने बताया कि कोल इंडिया के थ्रू और इंसेंटिव्स मिलते हैं, और पर लेकिन बच्चा ठीक होना चाहिए, इच्छा शक्ति होनी चाहिए। तो हमारे मुश्ताक जी के पास इच्छा शक्ति भी थी गवर्नमेंट से, और डॉक्टर संदीप ने इनका ट्रांसप्लांट किया। तो हम डॉक्टर संदीप और मुश्ताक जी से बात करेंगे। वो टू डॉक्टर संदीप एंड मुश्ताक। हाँ जी मुश्ताक जी।
सर, फर्स्ट ऑफ ऑल थैंक्स टू ऑल डॉक्टर्स एंड स्पेशली सर आपके लिए कि आपने मुझे इसके लिए जो है बुलवाया। जैन 6 मंथ का था जब उसको ये बीमारी डायग्नोज हुई, और मैं कलावती में फर्स्ट टाइम मैं आया उसको लेके, क्योंकि मेरा घर पास है कलावती के। तो इमरजेंसी में था, रिपोर्ट्स आने के बाद पता चला कि हाँ उसको थैलेसीमिया है। तो मैंने डॉक्टर से पूछा कि अगर बीमारी है तो इसका क्योर भी होगा। तो डॉक्टर्स ने बोला हाँ इसका क्योर है बीएमटी। तो मैंने बोला कर दो। तो डॉक्टर्स थोड़ा हंसे और बोले कि ये इतना सिंपल प्रोसेस नहीं है, थोड़ा कॉम्प्लिकेटेड है और बहुत कॉस्टली है। देन उसके बाद ट्रांसफ्यूजन चलता गया, और उसके बाद फिर एक राजीव गांधी में एक कैंप लगा एचएलए टाइप का। हमने वहाँ पे उसका टेस्ट कराया। थैंकफुली उसके ब्रदर से, उसके सिबलिंग से उसका 100% मैच हुआ। और फिर उसके बाद डॉक्टर संदीप ने और सर ने सारा हमको प्रोसेस जो है बताया कि कहाँ से फंड आएगा, क्या आएगा। कोल इंडिया से 10 लाख का फंड और पीएम केयर फंड से 3 लाख का फंड आया। तो 27 जनवरी 2024 में उसका ट्रीटमेंट स्टार्ट हुआ। 1 महीना वो हॉस्पिटल में रहा। आई एम वेरी थैंकफुल टू डॉक्टर संदीप जैन, डॉक्टर गौरी कपूर एंड डॉक्टर पायल। उन्होंने मतलब हम पेशेंट्स ना बहुत ज्यादा मिसकम्युनिकेशन होता है हमारे अंदर कि सिबलिंग को कुछ हो जाएगा, बच्चे को कुछ हो जाएगा, परसेंटेज क्या चीज होगी। तो ट्रीटमेंट के साथ साथ ना एक सही गाइडेंस देना भी बहुत जरूरी है पेरेंट्स को, मतलब एक सही चीजें बताना। तो फाइनली मेरे बच्चे को 15+ मंथ हो चुके हैं बोन मैरो ट्रांसप्लांट को। उसको कोई नीड नहीं हुई है अभी तक ट्रांसफ्यूजन की। वो बहुत अच्छा है, हंसता है, खेलता है, बहुत एक्टिव है। तो थैंक यू सो मच सर, आप सबका, मेरे बच्चे के लिए और इन सारी चीजों के लिए सर।
और आपको कितनी कितनी सपोर्ट कहाँ से मिली?
सर मुझे 10 लाख रुपए कोल इंडिया से एंड 3 लाख रुपीज फ्रॉम पीएम केयर फंड।
राइट, राइट। तो क्या आप औरों को मोटिवेट करना चाहेंगे बोन मैरो
श्योर
ट्रांसप्लांट?
श्योर सर, श्योर। और मेरी ये कोशिश होती है कि मतलब जितने भी मेरे नोन में है, या मैं कलावती भी मैं लास्ट टाइम आया था बच्चे की वैक्सीनेशन के लिए लास्ट सैटरडे को। तो मैं वार्ड में प्रॉपर बता के गया हूँ कि किसी चीज से डरने की जरूरत नहीं, आपको पैसों के लिए डरने की जरूरत नहीं, आपको किसी चीज की डरने की जरूरत नहीं। गवर्नमेंट आपके साथ है, सीएसआर इनिशिएटिव आपके साथ है, और बस आपको हिम्मत रखनी है, आपको एक जज्बा रखना है कि नहीं हमें अपने बच्चे को 2 से 3 महीने देने हैं ताकि वो स्वस्थ और सकुशल जिंदगी जो है जिए और उसके लिए आगे जो है बढ़ता रहे। तो हम पेरेंट्स को पैसों की चिंता नहीं करनी है, हमें सिर्फ अपना थोड़ा सा टाइम देना है ताकि वो अपनी जिंदगी पूरी तरीके से और अच्छी तरीके से बिता सके, जैसे हम लोग जो है बिताते हैं। और सर मेरा एक वो मोटिव था, लास्ट टाइम मैंने कोल इंडिया का भी सेमिनार था थैलेसेमिक इंडिया डे पे। तो उसमें मैंने एक छोटी सी बात बोली थी कि हमारे इंडिया का रेशियो जो है वो 10,000 बच्चे का है पर ईयर। तो सर ये अवेयरनेस ही होगा और ये हम सबकी कोशिश होगी, और ऐसी अवेयरनेस प्रोग्राम होने से ही कोशिश होगी कि जो 10,000 का एक है ना उसको हमको जीरो में बदलना है सर, है ना सर। तो ये सिर्फ ऐसे इनिशिएटिव, ऐसे प्रोग्राम्स, ऐसी अवेयरनेस के थ्रू कि जब आप शादी करें तो एक छोटा सा टेस्ट करा लें, है ना। बच्चा अगर मदर प्रेगनेंसी में है तो एक छोटा सा टेस्ट, क्योंकि ऐसा बच्चा मतलब जिंदगी में आने से पहले मतलब अगर आप उसको टेस्ट कराए तो एक परिवार और एक बच्चा इतनी बड़ी परेशानी से बच सकता है सर।
धन्यवाद। तो आप एक
वेल
चीज
सेड।
अगर कुछ बदलनी हो तो क्या बदलना चाहेंगे थैलेसीमिया केयर में, मुश्ताक जी?
सर थैलेसीमिया डे के सर, वन ऑफ द बेस्ट ट्रीटिंग हॉस्पिटल कलावती। मैंने 4 साल वहाँ पे जो है ट्रांसफ्यूजन कराया है। सारी चीजें जो है अच्छी हैं, टेस्ट सारे टाइम पे होते हैं, सारी चीजें मतलब बेस्ट फैसिलिटीज है सर कलावती में, बेस्ट बेस्ट ऑफ द
नहीं
बेस्ट।
नहीं, बेस्ट नहीं, आप क्या
हाँ,
बदलना चाहेंगे थैलेसीमिया में, वो बताओ, हमारा
अच्छा सर,
छोड़ो।
अच्छा अच्छा, ठीक 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 है सर। थैलेसीमिया में सर जैसे गवर्नमेंट ने मैंडेटरी किया हुआ है प्रेगनेंसी में एचआईवी टेस्ट, राइट। प्रेगनेंसी में गवर्नमेंट का मैंडेटरी है कि एचआईवी टेस्ट कराना चाहिए, वैसे ही सर एक थैलेसीमिया का भी टेस्ट मैंडेटरी होना चाहिए सर,
राइट
ताकि
राइट
हाँ,
राइट।
ताकि ऐसे बच्चे जो हाँ, तो ये मैंडेटरी
प्रिवेंट ही
हो
कर
सर।
सके। ठीक
एग्जैक्टली
है।
सर, हाँ।
मुकेश, लेट मी
धन्यवाद मुश्ताक जी। हाँ संदीप प्लीज, आप ही को बुला रहा था मैं।
हाँ,
प्लीज।
नहीं वो मुश्ताक, आई मस्ट से
हाँ।
कि ये पूरी फैमिली
हम्म,
बहुत डेडिकेटेड थी, कमिटेड थी,
हम्म,
नेवर
हम्म,
मिस्ड एनी अपॉइंटमेंट एंड वर वेरी
हम्म,
केयरफुल इन undergoing transplant and took good care of the child. But
हम्म,
again, the message is, say we have like 10,000 new thalassemia born every year. Transplant
हम्म,
कितने बच्चों का होगा? ट्रांसप्लांट हो रहा है सिर्फ 1% बच्चों का, 2% बच्चों का. इफ वी सी, द मेजर फोकस इज नॉट ऑन द बोन मैरो ट्रांसप्लांट. मेजर फोकस ऑफ आवर
हम्म,
शुड बी हाउ टू प्रिवेंट बर्थ ऑफ ए थैलेसेमिक चाइल्ड. जैसे मुश्ताक जी ने बोला, बिल्कुल ठीक बोला कि जो ये 10,000 है इसके आगे से एक हटाना है हमें. तो हमारा जितना भी फोकस, जो कम्युनिटी केयर का फोकस है, कम्युनिटी केयर का फोकस कभी भी बीएमटी पे नहीं हो सकता है.
हम्म,
बीएमटी तो एक छोटा सा चंक है जो बच्चे करवा पाएंगे जिनकी कंडीशन अच्छी है, जिनका मैच सिबलिंग डोनर अच्छा है, जिनके पास फाइनेंशियल एक्सेस है. बट
हम्म,
मेजोरिटी ऑफ आवर फोकस शुड लाई समहाउ ऑन प्रिवेंशन ऑफ बर्थ ऑफ ए थैलेसेमिक चाइल्ड. एट द सेम टाइम, थैलेसीमिया मेजर कि में बीएमटी इज वेरी effective, very safe these days, and in fact
हम्म,
with this thalassemia बाल सेवा योजना हमारे यहाँ पर 200 से ज्यादा एलोजेनिक बोन मैरो ट्रांसप्लांट हम कर चुके हैं. एंड of those more than 200, more than 90% are doing well. So that way, अब वैसे देखें तो overall, if we see the figure, only 200 patients have undergone transplant in such a big tertiary care center, which is nothing compared to burden of the thalassemic care that we have in our country. So I think these two should go hand in hand, but our major focus should be how to improve the care of thalassemic child, how to prevent the birth of thalassemic child. That should be the main focus, and at the same time our some effort should be directed towards the cure of the patient who are. Important message for pediatricians and for every general physician that I would like to give is, the earlier we do the transplant, the better is the outcome. खर्चा भी कम है उसके बाद, और उसका आउटकम भी अच्छा है if somehow we can transplant thalassemia children in the age group of 2 to 6 or 2 to 7 years of age. That is the best time. Although the government gives us fund for up to 12 years of age, but still 2 to 7 is the best time.
So डॉक्टर संदीप, इस कोल इंडिया प्रोजेक्ट के बारे में थोड़ा सा और बताएंगे? Could you just
So,
appraise us more
so,
about it,
so जो
please?
Coal India project है, it was started in 2014 actually, and if we see now, it has been like 10 years, and our hospital was associated with this right from the inception. And in this, actually, the initial was less than 12 year of child who have like match sibling donor. The government provides 10 lakh rupees of financial assistance, as Dr. Manas also told. Now, there are many hospitals across Delhi and NCR which are given this facility. And generally, whenever a child comes to us with an option of bone marrow transplant, we first try to see whether this child is fit enough for undergoing transplant. We keep this child under our care for 6 to 12 months to make sure that his regular blood transfusion is maintained, chelation is optimized, his liver kidney functions are normal, heart function is optimized. And in this intervening period, we know that he is not going to be transplanted in 10 lakh rupees. He will require at least 15, 17 lakh rupees. So somehow we arrange 5 to 7 lakh rupees for that child in this 6 to 8 months, and that is through either Prime Minister Fund, through NGOs, or through some donors that we have in our uh, registry. So with this, and with a clear understanding that family understands about the transplant, we never push anybody for transplant. We actually tell them that there is so much of risk and so much of complications that are associated with allogenic bone marrow transplant. Once family completely understands it and is motivated to uh, go through this, because it is not just the finances and the infrastructure, it is the post-transplant care which is also essential. If the family is not motivated, the post-transplant complication will be more, and the chances that whatever you have done during the transplant will be undone during the post-transplant period. So that 6 to 8 months is very important for optimizing, counseling the family, and also making family aware about the different phases of transplant. So I think it's a journey. which we go together with the family. And most of the time, in this 6 months, we are able to convince family about what they are going to face and how they are going to face. So it's a tough, challenging work. But if the child is transplanted at the right age, the outcomes are very fruitful and rewarding.
So, right. So, I would like to summarize in a way that bone marrow transplant is the only curative option for transfusion dependent thalassaemic children. And we are lucky enough to have Dr. Sandeep Jain and Dr. Manas Kalra with us who do bone marrow transplant for these transfusion dependent thalassaemic children through Coal India, which would eventually be kind of free of cost for the patient. So I would like to request all pediatricians, esteemed IAPNs, esteemed pediatricians who are listening to us right now, if there is a child with transfusion-dependent thalassemia, do motivate them for bone marrow transplant, as we now have an option of free bone marrow transplant if there is a matched sibling with us. So I think with this, we come to the end of the panel discussion today. I would really like to thank Dr. Manas Kalra, Dr. Sandeep Jain, and Dr. Varsha Mishra for the same. Thank you, and over to Dr. Radhika.
Thank you so much, Dr. Mukesh, Dr. Manas, Dr. Sandeep Jain, and Dr. Varsha. Any questions from our panelists?
Yeah, I have a question. One thing is, what about the post-transplant care for these patients where you are giving the bone marrow transplant, stem cell transplantation?
So, generally, these patients require immunosuppressive drugs for a year or so after transplant. And after that, they require revaccination. This is the two major things that they require after transplant. And I would say approximately 30% of the cost of entire thing is in the post-transplant care. And this Coal India Fund is actually not applicable for post-transplant care. So in that scenario, what we do, we allocate a budget of around 3 to 4 lakhs for the post-transplant care, because we know that these children will be severely immunocompromised for next 1 year or so. So they are very predisposed for infection. And also they can get graft versus host disease, which is a complication of allogenic bone marrow transplant. So we have to be aware of it. So these children are confined to a place close to the hospital for some time, for a month or so, and then in a very hygienic, place, they have to stay for next 4 to 6 months when the full immunosuppression is going on. Yes, but after a year or so, they are not on any medications and they can live a normal life like any other child.
The thing is, when I was searching in the
Vaccination will
literature,
be needed.
I found
All these children will need vaccination, but that
Okay,
vaccination is generally done 1 year after the transplant. So they will need all vaccination because the transplant removes that immunity that they have had through the previous vaccination. So pediatrician's role comes up in a big way because we have to vaccinate these children, and also sometimes we have to iron chelate them later because their iron overload can persist. So we have to iron chelate them later.
so I have two more questions actually. Can I ask?
Sure.
Yeah. So another one is total overall outcome of the bone marrow transplant. That is the one. And the second thing, we have robust IAP West Delhi site, website, and this actually, and we also have the YouTube channel. I will like to have this address and the where to contact about the project for the financing and all. So I invite your write-up or something where you can write for us and we can put in a website as information and also precaution, also eligibility criteria.
And there
So
is a
thank
good
you so much.
brochure. There is a good brochure by Thalassemia Bal Seva Yojana. That brochure gives the eligibility criteria, and it also tells all the centers where this facility is available. We will give it to you and you can post that. It's a nice pictorial thing. If you post it in the group, everybody in your group will come to know about all the centers and also about the eligibility criteria. We'll give it to you, ma'am.
So that is okay, but I will. I am actually dil mange more wali baat hai. So I will like to have that small write-up for the our
Yeah,
IAP
No, sure.
we will
website.
do
No
that.
problem.
We will do
No
that.
problem.
No
The
issue.
write-up also we will give. No problem.
And
Right.
then you can make a song out of it. I know it was so beautiful to hear that song.
Yeah, what?
And you can make a song out of it, because the initial song was so useful, and I think most of the message in that song were very helpful, I think.
So I
It's in
have
Including,
Hindi
Hindi
also.
including
also.
gene therapy. It had
Including
gene
gene
therapy
therapy, yes.
also
So that was
included.
another thing is what about gene therapy, and I have written a
Evolving.
Hindi version also, but I could not make video for that. That is smaller, so I will float that also on YouTube.
Thank you.
Thank you.
Any more
I
questions
would
from
like to
anyone?
say thank you.
Yes,
This was a
yes,
wonderful
just
presentation,
one
Dr.
query
Manas.
was there. What is the youngest age of the bone marrow transplantation? Any age limit, young age, safely we can do.
So generally we avoid it in less than 2 years of age, and in infancy definitely not. But anytime after 1.5 or 2 years of age, we can take them for transplant.
It can be done.
Yes.
And the relation with the serum ferritin,
So generally, if we do it at 1.5 or 2 years of age, serum ferritin is not an issue. By that time, serum ferritins are not high. But in older children, I try to not to take patients more than 2,500 or 2,000 nanogram per ml for ferritin. We try to optimize their chelation, optimize their blood transfusion before we take them for transplant.
thank you, sir.
Dr.
Thank you
Richa,
so
you
much.
were asking
Yeah.
something?
Wonderful,
Yes.
wonderful presentation, sir. Thank you.
Firstly, I would like to congratulate all the faculty members. It was a wonderful presentation. Very valid points have been mentioned by Dr. Manas, Dr. Sandeep, and Dr. Mukesh, as well as the parent that we have taken, has given us very valid points. I have one question to Dr. Mukesh Dhankar. Is the mutation analysis available in Kalavati, and how frequently we are doing it, if we are doing?
So mutation analysis is episodically available in Kalavati. So whenever it is available, we try to do, as Dr. Manas has mentioned, it's better to get it done. But if when during the time when it is not available in Kalavati, we try to get it done from a private setup. But it is preferable to get it done.
Okay. Thank you. So we can have a word with you and send the patient.
Yeah. Whenever that is available, I'll get it done. Should
Okay,
not
very
be a
valid
concern.
points. One, prevention is better than cure. Second, motivate for bone marrow transplantation. And third, vaccinate and try to maintain the ferritin levels less than 1,000. And
Right.
And
Kol
tell
India and
tell
Lal
all
Seva
your
Yojana.
obstetrician, tell all your obstetrician and gynecologist friends to always check thalassemia status of the mother. If positive, check the father. So that is most important. You know how we started that prevention is better than cure, and everybody echoed in that message. If we want to have a control on thalassemia, it can only come when our obstetrician gynecologist friends are in sync with us, and they make it sure that, you know, like we check hemoglobin, we check HIV, we check all the other tests, we make sure that thalassemia status is tested.
Yes.
मानस
Very
इसमें
well.
I would add, जैसे जन्म पत्री मिलाते हैं शादी के लिए, ये थैलेसीमिया ट्रेट मिला लें तो बेटर है.
बहुत जरूरी है सर.
Very good. Yes, sir. Very true.
So one
And what
question
if
from my side.
what if there is a love marriage?
नहीं तो लव भी ध्यान से
आप
करो.
थैलेसीमिया मिला लो ना. अगर लव मैरिज है,
उसमें सब माफ है
लव मैरिज
मैडम.
तो भी आप
लव मैरिज में सब माफ है.
परत पत्री मिलानी नहीं है.
Still you can
But it's
prevent
never too late.
birth. हम कभी ये नहीं कहते कि अगर आपकी लव मैरिज हो रही है और आप दोनों को थैलेसीमिया माइनर है तो आप शादी मत करो. दैट इज नॉट द मैसेज. मैसेजेस आप शादी फिर भी करो, बट जब आप प्रेग्नेंट हो तब आप थैलेसीमिया मेजर है तो चेक करो.
बिल्कुल.
अगर हमने ये बोलना शुरू कर दिया ना कि आप लव मैरिज मत करो, तब तो ये प्रोग्राम फेल है.
Exactly.
वो जेब से बाहर ही नहीं निकलेगी रिपोर्ट.
मैं ये जानना चाह रही हूँ, एक बहुत ही इंटरेस्टिंग मेरे पास प्रपोजिशन है. Somebody is making kind of a sickle cell scope. Probably they can make a thalassemia scope also, where you are like pulse oximeter, you can check the hemoglobin. So I was just thinking about that thalassemia trait. In trait, what is the best way to test for? Like it's a genetic testing or the hemoglobin testing? And the second thing, if somebody is making this scope, is there any way to absorb that production?
No idea.
In the government program?
No idea. I'm not
So
aware of any
the
scope, ma'am.
only way to best way to test is by doing
नहीं, you are, I
HPLC.
know
आप
actually so
HPLC
that.
करो, आप HPLC करो, HbA2 3.5 या उसके ऊपर आ गया, यानी पेशेंट को थैलेसीमिया ट्रेट है।
ट्रेट है,
तो आप सबसे पहले आप HPLC करो, म्यूटेशन टेस्टिंग करने की जरूरत नहीं है, आप
जरूरत ही नहीं है।
HPLC टेस्टिंग करो।
Okay.
स्कोप के बारे में पता नहीं मैम, बन जाए तो बताना मैम, वी वुड बी रियली हैप्पी।
बन सकता है because somebody is making sickle cell scope. The person was able to make, but the only thing is consumption is not there. So they are not bringing it out. Actually, they have made the sensor.
नहीं
So
पता,
that is
मैं तो
basically the getting the different spectrum of the hemoglobin, the various type of hemoglobin. So they have made that. Only thing is consumption. They want a place where it can be if they make it in a like business level. So
तो मैम वो तो
Madam,
स्क्रीनिंग टूल की तरह
counseling
यूज
and
होगा
इंडिया
ना।
से ज्यादा तो बिजनेस और कहीं किसी देश में नहीं मिल सकता। अगर ये चीज बन गई, इंडिया से ज्यादा इतने लोग हैं और इतना हाई थैलेसीमिया स्टेटस है, इंडिया से ज्यादा तो बिजनेस नहीं हो सकता। बट अभी तक जितने भी ये पॉइंट ऑफ टेस्टिंग है ना, पॉइंट ऑफ केयर टेस्टिंग कहते हैं, तो वो पॉइंट ऑफ केयर टेस्टिंग में थोड़ा भी थैलेसीमिया के लिए अभी भी HPLC ही बेस्ट माना जाता है।
thank you so much.
Madam,
कॉमर्शियल वायबिलिटी का तो कोई इशू नहीं होगा इफ यू सी 140 CR एंड देयर 4% इंसिडेंस ऑफ थैलेसीमिया माइनर, सो यू हैव लाइक 5 to 6 crore of the people in India having thalassemia minor. So commercial viability is never an issue. It is just accessibility and how correctly it is identified. That is the major thing.
Madam, as Mr. Mushtaq Shah, he narrated the events. So it is very clear that the proper counseling was there and the excellent follow-up was there, which is a must in these cases. Now, that is why this is the way to success in these cases. Congratulations to the team.
Thank you.
Thank you so much. On Mushtaq ji, thank you so much for joining and sharing your story. And I hope the child stays well and healthy. And thank you so much on behalf of IIP West Delhi. I thank all of you.
Chairperson, please ask chairperson if they want to make comment. Probably Dr. Pankaj is there, Dr. Shravan.
Dr. Pankaj. Dr. Shravan sir, Dr. Pankaj.
Unmute, please.
You are not audible.
Hello.
Unmute,
Yeah.
sir.
I'm audible
After
now.
a very long time, I have heard such a wonderful discussion on thalassemia topic because these children are mostly neglected. They are just taken for granted. Even the parents sometimes consider these children as a burden. We have worked in thalassemia units during our uh, SR ship, during our residency. So, one point that was very excellent and given by the patient, that the diagnosis prenatal testing should be made mandatory. And as such, we are working in private hospitals. At least we can do this mandatory in our private hospitals, that there is a stamp of thalassemia tested on every antenatal card.
Very, very valid point.
Yeah.
Dr.
Thank
Shravan
you.
sir.
Yeah, it was a wonderful discussion, especially the refreshing the knowledge on thalassemia. Only thing is that we have to be aware of these things whenever a child comes to us for any routine checkups, like at the age of 3 months, 4 months, we have to check the child for at least basic things like anemia, and then like make the petosplenomegaly. If at all it's visible, we should be investigated thoroughly. Only basic thing is CBC can be done, which Menzer index can at least give us some idea. If the Menzer index is less, then at least we should investigate the child for thalassemia. And awareness is what can detect the child at the early stage. Otherwise, it was a very refreshing knowledge for this, most of us. Thank you. Thank you very much.
Thank you, sir. We had gone to Deen Dayal Hospital, and I must say that they are doing such amazing job, and the doctors and the sisters, they also motivate the patients, because there was a child, there was a boy almost 19 years old, and he was asked to, he told that he's doing geography honors from Delhi University Venkateshwar College, and his primary area of interest is this. He plans to give UPSC. So children and people, they get motivated by hospitals and doctors and the correct guidance when they get. So it was a very enriching experience for me too.
Radhika ma'am, because you said this,
Anji.
I'll just interrupt you. We have a MD anesthesia student who is thalassemia major and a boy who is in IIT who is a thalassemia major. So, there is sky is the limit for these children. Even with good blood transfusion chelation, they can live a very good life. Ideally,
Yes.
transplant is the cure. But even if you can't do transplant, blood and chelation, if you do very nicely, they can live really good. Nowadays they can live up to 50-60 years if you do very good blood transfusion and chelation. But yes, it comes with regular blood transfusion chelation, which is a problem. So if possible, do transplant. And as you said, geography honors, UPSC, everything they will be able to do if we all work together with them.
Very
So
true.
my comment, one more comment, because it was surprising to me, but because there is a girl who was thalassemia minor and mother of one child. This is what sister told me. So that was really good that if pregnancy can be carried, then it's a good thing. And one question remains about the increasing the level of hemoglobin, fetal hemoglobin by certain drugs. So any opinion on that?
So, ma'am, in thalassemia minor, we don't need to give any drug, but definitely for non-transfusion dependent thalassemic, where occasional episodic transfusion is needed, we do give drugs to increase the fetal hemoglobin to maintain a HB around 7 to 8, or maybe 7 to 9.
These drugs are still experimental and they need to be
No, no,
given with
no.
great
The
cautious, yeah.
thalidomide is
Yeah.
experimental. Hydroxyurea is proven.
Yeah, hydroxyurea can be given, but like for thalidomide, which increase fetal hemoglobin levels, these drugs are given in trial mode. So currently, NAMES also a trial is going on in which low doses of thalidomide is being tried. So these children need to be under very close follow-up. Even I was a part of this trial in which we were giving low dose thalidomide along with hydroxyurea to induce fetal hemoglobin in these children. Initial results are promising, but it still requires a lot of validation.
So
Thank
I
you.
would just like to mention one thing here. This should be done only in a trial setting. At least I know 4 or 5 patients who received thalidomide and had secondary leukemias. So all these drugs are teratogenic. So unless it is like validated in big clinical trial, they should not be part of standard practice. So
I had one patient who had received thalidomide, and along with thalidomide, the patient was given erythropoietin. I was little surprised because erythropoietin in this there's already increased erythropoiesis. So it was in Bombay. Some doctor had given
So
thalidomide
that's
plus
what we are
erythropoietin.
exactly, sir. What we are trying to disseminate through with such webinars, that these are not recommended drugs. And if somebody is doing, maybe he should also be enlightened and made aware that these are not recommended drugs as of now.
absolutely.
Dr. Samarji?
Dr. Samarjeet?
I think he is left.
Okay, so Dr.
नहीं
Radhika.
आ गए
Hello, sir. बहुत अच्छा talk. It was very informative and very logical things contributed by parents of the patient also. I thank you, Mustaq, also for really motivating the patients.
Thank you, sir.
Hats off
Thank you.
to all. Hats off to you all. Thank you.
Thank you, sir.
Thank you, Dr. Samarjeet. So, on behalf of IIP Wesley, I thank all of you. Big thanks to Dr. Mukesh Dhankar, sir, for organizing this panel discussion. Thank you, ma'am. Thank you, and have a good day.
Thank you.
Thank you. Thank you, everyone.
Thank you, everyone, for having
Thank
me
you.
here. And it's great interacting with everybody. Thank you so much.
Just open, everyone, please switch on your videos so I can get a picture. Richa, please switch on your video. Anju, Dr. Arpita, Dr. Rahi, please switch on your video. Okay. Okay. Richa?
Thank you.
No.
Thank you.
Okay.
Thank you,
Please start.
everyone. Thank you, everyone.
Rashmi
Thank
Gandhi,
you.
yes. Rashmi Pankaj.
Thank you.
1 minute more. 1 minute. Yes. Rashmi, please. Yes.
Yeah, I was so inspired to listen to Mr. Mustaq. It's the story, the most inspiring thing that I heard today, and it will stay with me for a long time. And I really praise him for his perseverance and having belief in the governments and belief in Kalavati Hospital, where I have also done my residency from. So I'm so happy to listen to that, and the session was very enlightening. Thank you so much.
So now we leave. Thank you, Mushtaq. Actually, it was my special request for you. And thank
Thank you,
you to
ma'am.
Mukesh Dhankar that actually you had Mushtaq over here. So this was a
Thank
great thing. Thank you so much. It was really, I really wanted you here. Thank
Thank
you.
you, Dr. Mukesh. Special thanks.
Thank
you.
Dr. Mukesh चले गए.
you.
Thank you.
So, and Dr. Puneet, I think you should. Dr. Puneet is
Thank you.
our
Thank
close
you.
study.
Thank you, everyone. It was really a great session. Thank you.
And close
Very
the
interesting.
session, please, from your side, Puneet. You are the
Yes, ma'am.
admin. Yeah.
Okay, ma'am.